Thank you for inviting me to present my work at this work in progress seminar. As Dr. Hoffman said, my name is Markus Knudsen and a postdoc fellow. And today I'm going to talk to you about my projects on improving the effectiveness of colorectal colonoscopy surveillance for prevention of colorectal cancer. Just to begin with, a quick recap on the natural history of colorectal cancer, CSC. We have basically two pathways, the adenoma-carcinoma sequence and the serrated pathway. The latter is accounting for between 10 to 15% of the colorectal cancer cases. Both of these sequences or pathways have 4 steps. You have the initiation, the promotion, progression, and then the actual cancer. And one way of trying to prevent or decrease the risk of cancer is by screening, where you try to catch the progress in an early stage as possible. In the US, the current recommendations for screening, colonoscopy screening, is at the age of 45. And by screening, you basically have 3 outcomes. You will have the negative findings, you will have polyps or cancer. Where then, based on these findings, you will also be recommended colonoscopy surveillance within the 10 years for if you have negative findings. And if you have polyps, then you will be recommended surveillance within 3 to 10 years, depending on the findings, which is numbers of polyps, findings and size, and also placements and type. And then if you have cancer, you will be referred to surgery or chemotherapy. As you saw on the previous slide, all the current recommendations is only based on the polyp findings, ignoring other well-established risk factors for colorectal cancer, such as demographic factors and lifestyle factors. And recently, we did this study, which we published in the International Journal of Cancer, where we looked into the adherence of a healthy lifestyle in relation to colorectal cancer incidence. And as you see over here at the graph, you have a healthy lifestyle score indicated by having a higher number, the more healthy lifestyle you have, and the incidence of colorectal cancer up here. And you see here, we didn't find any significant association within the separate groups, but we saw a significantly trend across the groups, also indicated by the p-value of 0.03. Moving on with the issues with the current colonoscopy surveillance is that there are low to moderate quality for the supporting evidence, especially for the low risk adenomas and serrated polyps. We are seeing a poor adherence to the surveillance guidelines, resulting in overuse and underuse of surveillance colonoscopy. And we are facing a high and rising volume of colonoscopy versus limited clinical capacity. And the estimates is that around 25% of all colonoscopy exams is due to surveillance. So what we recommend or try to look into is, would it be possible to make a more tailored surveillance based on the individual's risk profile? To study this, I first have been investigating the adherence to surveillance recommendations in patients with high-risk polyps. We then moved on to try to develop a risk stratification tool for post-polypectomy CRC, PPCRC. And then I've been looking into characterizing the risk of colorectal cancer after a negative screening colonoscopy. To investigate this, I was so lucky to have access to the 3 population-based cohorts, the Nurses Health 1 and 2, and the Health Professional follow-up study. where we had lifestyle questionnaires and the endoscopy and pathological reports. I was also lucky to have access to a fourth cohort, the Mass General Brigham MGB colonoscopy cohort, which is an electronic health record-based clinical cohort, where we had pathological reports, clinical notes, and endoscopy reports. So for the first study of ours, I've been looking into we prospectively assessed the use of surveillance colonoscopy within almost 3,700 patients with high-risk polyps. First registered at first registered screening colonoscopy doing between 2007 to 2012 in the MGB colonoscopy cohort, and followed them to 2017. And then we accessed the compliance, overuse and underuse of the post-polypectomy surveillance according to the 2006 US Multi-Society Task Force on Colorectal Cancer recommendations. And the recommendations are 3 years for these high-risk polyps, individuals with high-risk polyps. And here we see the results and seeing a huge number. This is percentage, like so 62% of all these individuals were underusers. In this group, we included both those who had late surveillance, but also those who did not attend surveillance at all during the follow-up period. And we have to remember these are actually persons who are at high risk of developing colorectal cancer. Moving on to the next aim of mine, the prediction tool for PPCSC. In this project, I used the Nurses Health 1 and 2 and health professionals cohorts to develop the model, where we had almost 27,000 individuals with a polypectomy. And then we validated our model in the MGB colonoscopy cohort, where we had 77,000 individuals with a polypectomy. To start with, we had 20 predictors divided into within three categories: the demographic, clinical factors, and lifestyle factors. And we then used Cox proportional hazard regression with a backwards stepwise variable selection, and then started follow-up 6 months after polypectomy. And the final model within that we got in the Nurses Health and Health Professionals cohorts included age, sex, BMI, alcohol intake, histology of the index polyp, and having 3 or more adenomas, having a large adenoma more than 10 millimeters, proximal serrated polyps, and a history of prior endoscopy. And then also in the MGB, we included to the reach of cecal incubation of the index endoscopy, and also the bowel preparation of the index colonoscopy, as these are factors that has been from the literature shown that to be important factors for the risk of post-polypectomy colorectal cancer. And based on these factors, we then created a score. Then we did C statistics and calculated the area under the curve, and got an area under the curve of 0.71, indicating a decent model. We then did divide the score into high and low, under or over the median score, and address this to our validation cohort in the MGB. And here we see the Kaplan-Meier curve. Those with the red is those with high PPCSC score. having a significantly higher risk of developing post polypectomy colorectal cancer, also indicated here by the significant hazard ratio. We then also try to access the added value of this score for the tailored surveillance beyond the current recommendations, and conducted this separately in high-risk polyps defined by individuals with findings that that were giving recommendations of 3 years follow-up surveillance after the polypectomy. And here we again see also not as clear, but we still see the separation between the two, the high and the low PP-CSE score. And also we have a significant hazard ratio up here between for the high risk PP-CS score compared to the low. Similarly, we did it for the low risk polyps defined by the recommendations, which were a recommended surveillance after 3 years, more than 3 years after the polypectomy. And again, we also see here a clear separation between the two lines, and also a significantly higher risk of colorectal cancer for those with a high PP-CSE score. Also here, we did the C-statistics and got an area under the curve, a decent area under the curve for the model between 0.71 to 0.75. Moving on to the last project of mine, the characterizing the risk of colorectal cancer after a negative screening colonoscopy. For this project, I used the Nurses Health and Health Professionals cohort and looked into and compared participants with a negative colonoscopy screening with those who didn't have a screening, and then followed them from the baseline until the end of follow-up, and censored individuals at the date of first positive endoscopy, colorectal cancer diagnosis, death, or end of follow-up, and used Koch's proportional hazard regression with both screening and the covariates as time-varying exposures. And we started follow-up 6 months after colonoscopy for the screened one in the screening group. Some preliminary results here. It's only in the HPFS cohort where we see that we looked into the risk of colorectal cancer after negative colonoscopy. After 5 years, we see a significant lower risk. This was also seen at 10 years and also at 15 years. So to sum up, our findings highlight the urgent need for improving the delivery of surveillance colonoscopy for better use of the resources and also optimal CSE prevention. We managed to develop a risk stratification tool for prediction of post-polypectomy CSE, providing the proof of principle for a tailored colonoscopy surveillance. We did not include surveillance in the model, but we did stratified analysis on surveillance, and we got similar results as the results presented here. And further work are in progress where we will include both surveillance, but also other factors such as polygenetic score and the molecular features of the polyps. And lastly, the preliminary results shown here indicate that in patients with a negative screening colonoscopy have lower risk of colorectal cancer after 10 years, which is recommended at the current recommendations. So lastly, I would like to thank my supervisors and my co-authors, and also my funding institutes. Thank you.